Today's topic is Dubin-Johnson syndrome. Coming to the molecular mechanism of Dubin-Johnson syndrome. In Dubin-Johnson syndrome, there is a defect in MRP2. MRP2 is a multi-drug resistance related protein. It is also called CMOAT or multispecific organic anion transporter. This transporter is important for transport of organic anions from hepatocytes to bile canaliculi. And the organic anions are non-bile acid. The organic anions include both conjugated bilirubin, other glucuronide or glutathione conjugated substances. And one thing should be noted here that these transporters are ATP dependent. It is one of the ABC transporters. That means ATP binding cassette. The gene encoding MRP2 is present on chromosome number 10, Q22 or 23. Now, coming to the histological features of Dubin-Johnson syndrome. In Dubin-Johnson syndrome, you can find black liver because of epinephrine metabolites that are deposited inside the lysosomes. Now, coming to cross-sectional imaging in Dubin-Johnson syndrome, that is CT scanning. On CT image, you can see high attenuation of liver. Now, what are the clinical features in Dubin-Johnson syndrome? Those patients are mostly asymptomatic, or you may find mild icterus. And that icterus may be noted only during intercurrent illnesses, pregnancy, or with the use of OCPs, oral contraceptive pills. And in Dubin-Johnson syndrome, prurites will not be there. And you may find occasional hepatomegaly. Now coming to the epidemiology of Dubin-Johnson syndrome. It is equally prevalent in both males and females, and the incidence is more in Sephardic Jews, that is 1 is to 3000. Now coming to the lab tests in Dubin-Johnson syndrome. On oral cholecystography, biliary system will not be visualized. This is seen 4 to 5 hours post IV iodipamide. And in Dubin-Johnson syndrome, there will be decreased clotting factor 7. LFT will be normal except there will be conjugated hyperbilirubinemia. Now coming to urinary coproporphyrins, 75% will be type 3. In Dubin-Johnson syndrome, total excretion will be normal. But you will find type 1 as a predominant coproporphyrins, and the treatment is not required in Dubin-Johnson syndrome. Now coming to HIDA scan, HIDA scan in Dubin-Johnson syndrome. In HIDA scan in Dubin-Johnson syndrome, you will find a characteristic pattern. You will find delayed or no visualization of gallbladder and biliary system. Now coming to Rotor syndrome. Now coming to Rotor syndrome. In Rotor syndrome, there is a defect. In Rotor syndrome, there is a defect in the gene SLCO1B1 and SLCO1B3, and it encodes a protein that's called OATP1B1 and OATP1B3. And the function of this protein is to transport conjugated bilirubin from circulation into the hepatocytes. And it should be noted it is autosomal recessive condition like Dubin-Johnson syndrome. Now coming to the clinical features in Rotor syndrome. In Rotor syndrome, you will find conjugated and unconjugated hyperbilirubinemia, which is chronic and isolated. You will not find any hemolysis in this syndrome. And Rotor syndrome is a benign condition. There is actually defective hepatic storage of conjugated bilirubin. Now, what are the lab tests that you can find in Rotor syndrome? In the lab test, now what are the lab tests that you will find in Rotor syndrome? You will find prolonged retention of IV injected unconjugated bilirubin and ICG. You may find 50% reduction in transport maximum of BSP. and gallbladder is usually visualized by OCG, which is not the case in Dubin-Johnson syndrome. Liver histology will be normal. That was black in Dubin-Johnson syndrome. Now coming to BSP test in Dubin-Johnson syndrome and Rotor syndrome. BSP means bromosulphthalene excretion test. Now coming to the principle of BSP test. BSP dye is taken up by hepatocytes. It is conjugated and excreted into bile. Any defect in uptake, storage, conjugation or excretion alters the excretion curve. Normally, less than 5% of BSP remains in plasma at 45 minutes. In Dubin-Johnson syndrome, there is early retention at 45 minutes due to defective secretion. Then paradoxically, a secondary rise at 90 to 120 minutes because of BSP glucuronides leak back into the plasma. So the classic finding is biphasic plasma curve. Now coming to the urinary coproporphyrins in Rotor syndrome. In Dubin-Johnson syndrome, you have seen the total excretion is normal, but in Rotor syndrome, total excretion is increased by 250 to 500%. Here, the predominant will be type 1, that is greater than 65%. Again, it's a benign condition and no treatment is required in Rotor syndrome. What is GGT? GGT is gamma glutamyl transferase. It is found in the cell membranes. It has a wide distribution. In the liver, it is found in the cell membranes of cholangiocytes and hepatocytes. It may be found in other organs like kidneys, pancreas, spleen, heart, and brain. The serum levels of gamma glutamyl transferase are equal in both males and females. And it should be noted in pregnancy, GGT levels, that is gamma glutamyl transferase levels, don't rise. Now coming to the function of GGT. The main function of GGT is the metabolism of glutathione or glutathione xenobiotics. With increased levels of GGT, in presence of metals, transient metals, there is pro-oxidant activity, which leads to RBC membrane damage. With RBC membrane damage, there is release of toxic transition metals, leading to pro-oxidant reactions and downstream cell DNA damage. For liver diseases, elevated GGT levels have high sensitivity, but the specificity is low. And it should be noted that GGT levels are not elevated in bone diseases. It may help in distinguishing whether the disease is secondary to cholestasis or due to bone diseases. There are some drugs that may increase the levels of GGT like phenytoin, barbiturates, NNRTIs, protease inhibitors. And with alcohol, you may also find there is increased gamma glutamyl transferase levels.